Good afternoon, Doc. We have an Invisalign case that we want to plan well, in great part due to the patient's compromised periodontal status. Evidenced by the photos here, I think we can get a sense that the patient has a pretty thin gingival biotype and already has recession. So the last thing we want to do is increase the problem through orthodontic movement without some sort of long-term plan. The challenge that we have right now, at least in our market, is the periodontists are booking out almost a year. And as a result, patients are motivated, they want to get stuff done. So we're kind of left with the bag when it comes to decision making on patients like this. So I'm going to kind of build into this plan the fact that the periodontist won't see the patient until after the orthodontics is completed. Obviously, in an ideal world, we would send the patient to the periodontist and give them some sort of insight on what we want to do. And what I'll often do is I'll go to the table, tooth movement analysis. Here we have 3 and 30, and I'll look at how much translation in a buccal lingual dimension there is. And here we have 2 millimeters. So I would say something to the effect of, we plan on buccalizing these teeth 2 millimeters from the current position. Please provide us guidance on the periodontal status as a result of that movement. What we're looking for is, don't move the tooth, or let me graft it first, or move it and then let me graft it, something to that effect. Good risk mitigation strategy to build the specialist into a case like this, for sure. But just taking a step back at the patient's situation, missing number 10, sagittal relationship, class 1, no missing premolars, overjet is sufficient, somewhat class 3 molar relationship here. If we have class 3 on one side and class 1 on the other, we should see a midline shift, which we do. Bolton analysis, let's take a look at that. Yeah, pretty good Bolton discrepancy here. So looking at this situation, it looks like the 1, 2, 3, 4. Sometimes when it's a pretty significant mandibular excess, there's an extra premolar. I say sometimes. I've seen it happen. I would say the bulk of the Bolton discrepancy comes from these narrow incisors. So it's good to know what the problem is, because the solution should always aim to try to address that initial problem. So if we're going to do IPR on the lower, I think we're missing the boat. I'm concerned that this patient might have an airway problem just based on the recession that we see here. We could dive into where the hunch comes from. It's an airway patient based on this. Let's take that sidebar for a second. When patients have thin biotypes, that doesn't mean they're going to have recession. There needs to be some sort of additional insult or irritant to induce the loss of bone on the facial and or tissue. More often than not, airway compromise causes sympathetic tone activity, so the muscles are more likely to be active, which could destabilize teeth. We see more fremitus in airway patients. We see more recession in airway patients because of that. The patient does have, let's see, this crossbite of the canine could be the reason that we have posterior issues. As a matter of fact, I'm actually wondering if the photos I'm looking at, yeah, this might be 14 and 19, and I wouldn't be surprised if that was the case based upon the uncoupling. I wouldn't say the uncoupling, but the lack of proper coupling of the canines on that side increased the chance of posterior tooth issues due to lack of canine guidance. So again, coming back to canine guidance, we have a whole video on that. Canine guidance discludes the posterior teeth during lateral function. If you have loss of canine guidance, the posterior teeth are not protected during lateral movements, and you might have one of many different sequelae. One is recession. Another is worn teeth, fractured teeth, loose teeth, joint pain, muscle issues. So there's a whole host of issues that arise when we lose canine guidance in some patients. Not everybody, but some patients. So I can't tell based on the photo here, but I'd be curious to know if that's 14 and 19. Because I can see the retractor here, I'm thinking that's actually the right side. And then looking at this photo, I can see it. So it's very possible that the lack of canine guidance here is actually inducing a contralateral interference of the molars. So it's not always on the side, the ipsilateral side, that we tend to see the problem when canine guidance is in an aberrant state. But coming back to the problem with the Bolton, it's these narrow teeth that I think is the problem. So my suggestion, based on the hunch that there's an airway problem, is that we actually increase space here and veneer the 4 front teeth as part of a aesthetic rehab to fill this. So I don't know what the plan is, whether it's an implant or a bridge. You had sent me a photo of this here, this cantilevered bridge or cantilevered single unit bridge. I don't hate the idea. If I was going to do it, I'd do it off the canine. If you're going to do it, the upper lateral is probably the only tooth in the mouth that really lends itself to doing that, based upon the decrease in biomechanical load in most people. But this patient screams to me as a biomechanically compromised patient, evidenced by the recession. So the recession, in my eyes, is biomechanical and genetic. That genetic leads him to a thin biotype. But there's a biomechanical component, and I'm just less likely to do a single pontic FPD on a patient of that sort. So I'm much more likely to say do a 3-unit bridge and then 2 veneers here, maybe 3 veneers. And we actually increase the spacing here to increase the overjet, but also to optimize the aesthetics of these teeth as part of the rehab for this tooth here. So a 3-unit bridge, 3 veneers, and we use Invisalign to increase the spacing here to give us much better width to length ratios of the current teeth versus IPR in the lower. So when do we do IPR in the lower? When there's not an airway problem and when there's triangular teeth. And these teeth are pretty rectangular. So doing IPR in rectangular teeth, slenderizing those aesthetically looks funny. It's harder to do good IPR in these teeth. And I fear that we're running the risk of making the garage smaller for the car, or the cage smaller for the tiger. In other words, restricting the tongue. So getting a sense of whether this patient's an airway patient or not might be a good idea. Maybe you've done that, maybe you haven't, but I would definitely start there. If there's any thought that there's an airway patient here, I would just let the patient know that IPR in the lower is really not on the table. There are no studies, to my knowledge, that articulate when IPR is good from an airway perspective. I have no doubt that study will happen at some point, but we're still in the infancy of bringing airway into dental treatment planning. So it'll probably be a decade or 2 until we get that clear understanding. Until then, I'm just super cautious. So I don't like the idea of IPR here as a way to solve the Bolton problem. Not to mention, the problem is the uppers, so let's fix the uppers. Let's just say the patient doesn't want to do that. Well, let's see what Invisalign gives us. See, the problem here is that this expansion back here for a patient that is already suffering from severe recession, I'd probably turn off all of the buccal movements on the posterior teeth in this patient. I might even freeze all of the teeth. But then what are we really doing? Are we limiting the expansion for this patient simply based on their risk for perio? Yeah. That limits us on what we can do with the rest of the mouth, but it does decrease the chance of having posterior recession issues. One thing that might come into play here is expansion, MSE. using a mini screw skeletal expander increases the alveolar bone width, which can help airway if airway's there, but more importantly, it allows us to get expansion without dental expansion in a patient that has high perio risk. So MSC would be something worthwhile considering. I don't know what the patient's chief goals are here, or chief complaints, and what your goals are for the patient. I don't love the idea of IPR on the lower. I also don't love the idea of how big this space is in relation to this. So if we come over to, typically on the Bolton analysis, it'll give us the widths here. So number 7 is 6.29. That's a pretty narrow tooth. And then the proposal here is actually to widen that space to 7.5. So we're going to have asymmetry on the laterals, which may or may not be important to you and or the patient. That's not going to get any better with IPR alone. So I like the idea of expanding upper 6 to 11 or upper 3 to 3, make everything symmetrical, and then veneer and crown everything, or do an implant. So let me know how that goes. If the patient's against all of that, let's really dive into whether IPR is the right play here or not. But I would definitely turn off all of the expansion on the posterior until you get a periodontal consult. And one of the ways you could do this is actually stage this, tell the patient you're going to fix all the front teeth. When he gets the periodontal consult, then consider expanding the posterior teeth. For what reason? To increase the buccal corridor for aesthetics, I guess. Other than that, I don't really see the purpose of trying to fix the posterior teeth, other than maybe just some increase of overjet here. To me, it's all about this canine. That's all you really need to focus on. And talk to him about composite here or Emax to increase the canine guidance. And I can help with that if needed. All right, keep me posted.